Excellent. Dr. King, how are you, sir?
I'm great. Good afternoon, everyone. Thank you for joining us.
Wonderful. Okay, well, I just wanted to, Joe, before I kind of bring you into the conversation, set the frame for everybody for what is the best expectation of how we can use our time together. And really, our goal is to be your guide, to help you with answers to questions, to provide you with the knowledge that you need to decide whether or not you want to find out if you're a candidate. We're not here to try to convince you to have surgery one way or the other. We just want to help you be informed. And so the way that we're going to do that, again, is via the questions that we're going to be answering for you. And then we'll have an incentive for those people that want to schedule the next step in their journey. And Christian will outline that kind of near the end of our time together. But Dr. King, I just want to let you know that roughly 75% of people are 50 and above. We've got just under 25% of people are in the 40 to 50 range. And then we've got roughly 5% of people that are, sub 40. So maybe with that in mind, can you kind of give us some opening words and let's get after it?
Great. Well, welcome, everyone. There are options for those of you who are interested in reducing your dependence on glasses and contact lenses. There are a number of procedures that we offer. Our practice specializes in vision correction surgeries, and the practice began from my side as a LASIK surgeon for most of my career, joining with my colleague, Dr. Andy Kopstein, who is an intraocular surgeon for much of his career. And together, we're both offering a spectrum of procedures, including LASIK, which is treating the cornea to change the shape of it to eliminate nearsightedness, farsightedness, or astigmatism. There's also PRK, which is another corneal-based surgery. We do implantable contact lenses, which are an excellent option to correct nearsightedness and astigmatism. And then for patients who are 50 and up, our favorite procedure now is what's called a refractive lens exchange. And a refractive lens exchange is removing the aging dysfunctional lens from the eye and replacing it with an implant. And the reason a refractive lens exchange is not favored for younger patients like 20, 30, 40, patients in their 20s through 40s is that the lens is still youthful and it's able to provide some range of vision from distance to near. But beyond 50, most patients have lost the flexibility in their lens and it's no longer able to provide that utility. And most people are going to be wearing bifocals or reading glasses after 50. So it just makes sense to remove the lens and treat the prescription in that manner. And that's a permanent procedure, which never needs to be repeated. So
I
that's
was,
kind of the big picture of what we're able to offer
yeah.
people in our practice. And here you see a picture of the eye with the cornea at the very front, which is where we treat patients with LASIK and PRK, and then behind the colored part of the eye called the iris that's where we can slide in an implantable contact lens for patients who are typically under 45. And that's a great method to correct nearsightedness and astigmatism. And then you'll see in this picture a clear lens. Well, this is how this is as clear as the lens probably is in childhood, but by the time most people are 40, that lens is yellowed, and by the time most people are
Yeah.
55 or so, there's some early cataract, and by the time people are 70, it's pretty brown and cloudy, and that's a dense cataract. So that almost always needs to be removed by the time people are 75.
So I was wondering if and what I'll do right now is I'm actually going to put up, ladies and gentlemen, the questions. There's quite a few that we have, and so what I'm going to do is I'm just going to kind of give you a bit of a feel for what we're going to be covering today. And again, we'll do this FAQ style. So if you have a specific question, please post that in the FAQ, and we'll get to them as quickly as possible. So we're going to talk about the differences between the procedures, but I think we just kind of covered that. I do want to spend a bit of time talking about EVO ICL. What is RLE? Again, sometimes you need to hear things a few different times. We'll talk about how long these procedures take. Will you feel any pain during them? Can they treat astigmatism? A big question for those of you is like, hey, if I do RLE, will I need to get cataract surgery in the future? And so we'll go through things like limitations on activity, side effects, pricing, of course. Is it covered by insurance? How do I know if I'm a candidate? and whatnot. So there's quite a few things that we want to go through. I wanted to maybe Dr. King, can we just talk again about the differences between the procedures? Is there anything else that maybe we haven't covered about LASIK, ICL, PRK, and comparing that to refractive lens exchange, or are we good on that front?
Well, again, LASIK is a corneal-based surgery. It was an extremely popular procedure, and remains extremely popular. But hundreds of thousands of people get this procedure every year. It really is ideal for people who are between 18 and 45, even up to age 50 or 55. But because LASIK does not change the lens inside the eye, it does not stop the eye from aging. It does not stop the eye from developing presbyopia, which is that age-related need for reading glasses. So people kind of age out of the LASIK demographic once they hit about 50 to 55, and then we begin to favor just replacing that lens. And as recently as, say, 5 or 10 years ago, we really weren't doing a lot of refractive lens exchange surgery, as the lens technology had not yet been developed to the point where patients could obtain excellent quality distance vision and near vision. And now with new multifocal lenses, particularly the light adjustable lens, which is a lens that our practice specializes in, although we do use all of the multifocal lenses, we are able to offer patients 55 and up essentially a vision rejuvenation, where the vision is restored at distance, and there can be good reading vision as well. But LASIK's a great procedure. I've had it myself, and ICLs are another procedure that our practice specializes in. We do a fair number of ICLs, and for some patients, this is really an ideal solution, particularly those patients, again, 18 to about 45 or so. And this involves sliding a contact lens inside the eye behind the iris. And in that way, we can correct nearsightedness and astigmatism without touching the cornea. And that can be advantageous for patients with dry eyes. It can be very helpful for patients who know that at some point in the future, they might want to have a multifocal lens placed, because when we preserve the cornea, the corneal shape, it keeps all of those options open for the eventual cataract surgery or lens exchange surgery. But the biggest advantage of the ICL is its total reversibility. You can remove that lens and the eye will go back to normal. So if somebody's nearsighted or they have astigmatism and they're looking for a reversible procedure to provide them with freedom from glasses and contacts, an ICL is an excellent option. So whatever your age, there's a solution for you, typically, if you do want to get out of glasses.
So I'm going to, before I ask you the next question, I'm going to launch another poll, because we've seen a few people that I've been asking questions about if they've, hey, I've had LASIK in the past and whatnot. I'm going to kind of read a few of them. Teresa said, I had LASIK almost 20 years ago. It's lasted 10 years to the date. Should I do it again? Just a little bit of challenges there. I had Craig here had RK in 1992. I've got another comment down here. James is 55 and he had LASIK monovision back in 2017. So I guess the question from a few different people is, if I had any sort of refractive surgery before, whether it's LASIK or RK, what is that? How does that affect my ability to get my vision taken care of now that I'm finding that my lens is starting to fail? Like, what am I able to be a candidate? Can I have a refractive lens exchange? What are your thoughts, please? And just before you answer, 25% of people that are in the crowd have had LASIK before. So go ahead, please.
Okay, so if you've had LASIK before, and it's an extremely common procedure, as I mentioned, it's almost a rite of passage now for people who are in their 20s or early 30s to get LASIK. You can still do a refractive lens exchange, and if you've had LASIK, you've probably really enjoyed that clear vision. And as maybe it's 20 years later, and you're beginning to experience some deterioration in vision, that's an early cataract developing. So you can enjoy that good clear vision again by having an RLE done. But one thing to keep in mind is that you really want to be selective about the type of implant that's going to go in your eye. Because when you've had corneal surgery, whether it's LASIK or PRK or RK or any other procedure on your cornea, or if you've got a funny shaped cornea, the best lens, without a doubt, is the light adjustable lens. And why is that? Well, when you've had prior LASIK, it's going to change the anatomy of the cornea. It's going to flatten the cornea in the case of a nearsighted prescription. And that can decrease the quality of the data that our devices use to determine which implant power would be appropriate to go in an eye when there is a refractive lens exchange. And so we have decreased accuracy of the formulas. And the beauty of this light adjustable lens is you can adjust the prescription postoperatively to really dial in the postoperative refractive outcome. And that's its real benefit is the ability to just customize the vision postoperatively. So if you've had LASIK before, yes, you can do an RLE, but you want to have it done with a light adjustable lens, which is just a beautiful lens. My colleague, Dr. Kopstein, I hope he can join us soon. He's done more of these than anybody in the United States, and that's largely because we practice together. And I've done probably a couple 100,000 laser vision correction procedures. Many of the patients whom I've treated, this is, as long ago as 20, 25 years ago, they're now coming back because they're now in the demographic where their lens is failing and they're looking for a solution. And that's where the RLE with the light adjustable lens is a great option.
So I wanted to, and I'm thinking from a patient journey perspective, we'll talk about what actually happens during the actual procedures themselves, but maybe if you could kind of talk us through like the next step for somebody, which is really to have that conversation, to find out if they're a candidate. And I thought it'd be good to start there, and then we'll talk about what the procedures are like. So I know I have on the screen, I can kind of put up a few different nifty little pics of our practice, but let's talk about the finding out if they're a candidate, which is like that next step. Like, what is that like? What happens? And just kind of maybe detail out the preoperative exam, please.
Well, if you're interested in any of these procedures, you're certainly welcome to schedule a one-on-one Zoom consultation with one of us on our team, where we can discuss some of the specifics of your circumstance. Maybe you've got a specific question. Feel free to shoot it through here on the Q&A, and we can try and address it during the webinar. But the first step for most patients who enter our practice is to talk with us, whether it's over the phone or to do a Zoom consult like this, and we can advise of the options. And typically we look at what someone's age is, what their prescription is. So if you have the prescription from your glasses or your contacts, that is really helpful. But most importantly, we want to hear, what do you want?
Yeah.
Your vision. That's really, whatever your goals are, we can help you achieve that. But we need to hear what you're expecting. Do you want to have excellent distance vision? Do you want to have a range of vision? What is your occupation? Do you do a lot of night driving? These sorts of things are important considerations. Now, in order to determine whether someone is eligible for LASIK or PRK or an ICL, it is essential that a full exam is done in the office. We have to do imaging of the cornea to determine how curved it is, how thick it is, what the shape is, what the depth of the anterior chamber is, which is the space between the cornea and the iris, and so on. And these are important measurements that everyone needs to have done before we're able to state definitively, yes, you can do LASIK or PRK or an ICL. Now, if you're interested in a refractive lens exchange, you're certainly going to need a workup as well. We need to do measurements of your eye, including the length of the eye, the curvature of your cornea, and we have devices that tell us which implants would be appropriate for your eye. And that all is done preoperatively, and it's typically done in office. And then we have that consultation about the different lens styles. In fact, that's Dr. Kopstein, who's just joined us, probably just finished some of those conversations in the last few minutes with patients, talking about which lenses might work well for
Andy, how are you?
Hey, Mike, I'm good. Hi, Joe.
Great. So, Andy, just to kind of give you a little bit of context, we have roughly 75% of people that are here are 50 and above. We've had roughly 25% of people have had LASIK in the past. We have covered a few questions already. I wanted maybe just to kind of take a step back and give you an opportunity. I know that Dr. King did outline kind of that journey that happens with people's eyes as they age, but just want to give you an opportunity to kind of introduce yourself and kind of before we kind of ask you some questions straight out, any words you'd like to say to everybody, please.
Welcome everybody. Thank you for coming, and hello, Joe and Michael and Christian. If This is all I do every day is talk about lens implants. So if anybody has any questions, I'm here for you. And I think I came in on the tail end, Joe, of you talking about why we want to see people in our office.
Yeah.
And what I would emphasize is that I think at some point, every surgeon who's done a lot of surgery can look at somebody's eyes just in the slit lamp at the microscope and really have a sense for what is going to suit this patient the best. And I would say we go one step beyond that because we have a very robust database of outcomes, not just with the multifocal lenses, the ICLs, the Vivity lenses, but also with the light adjustable lens. And so there's statistics, and then there's also the surgeon's feeling about what might suit the patient's needs the best. And I think it's the latter part that is sort of the art of what we do. Um, I just had this conversation with a patient who is 53, just right before I came in here, who is trying to decide, do I do a multifocal lens or do I do a light adjustable lens? And these are the conversations that essentially we have with patients all day, every day. So I would emphasize that it is important to have that really good conversation with your surgeon prior to the surgery.
And that leads me, Dr. Kopstein, to the question I was going to get to right when you joined, which is detailing out like what actually happens on the day of the procedure. So somebody's come in, we've had that conversation, they find out that they're a great candidate. Now it's the big day. And I'll have Dr. King answer the LASIK ICL PRK side, but what can you tell somebody about what they're going to experience on the day of their procedure, and especially the coming hours and days afterwards, expectations on vision? Just what's that journey like, please, from a patient's perspective?
Well, I think first of all, whenever you go to a doctor's office to have anything done, there's a little bit of nerves. And so the first thing that we do is we dilate your eyes. We look at all of the parameters that we've either previously measured or that we're measuring on the same day. And the surgeon examines you. At that point, we answer all of your questions. So before you come in to see us, we give you this informed consent document, and we really want patients to read through that so that they can highlight anything that is of concern for them, because we would rather answer those questions than have somebody lose a night of sleep. So in general, I'll even go before the day of surgery. As surgeons, we call our patients before surgery, and we make sure that all of the questions are answered. So that just lets you have a good night's sleep. You're not feeling as nervous as you might if you're just meeting somebody for the first time. After that, we dilate your eyes. We give you medicine that will not just take the edge off, but also make you feel like you just don't care about anything. And at that point, the patient is ready to have the surgery done. It is a painless surgery because we do it with so much anesthesia that on the surface of the eye, inside the eye, and if needed, even by injection, which is rare, but it's available. And the patient feels very comfortable and does not have any pain during the procedure. For most of us, the surgery will take 5 to 6 minutes for each eye. You have your new lens implants in, things are blurry on the first day. You go home, we recommend that you close your eyes as much as you can on the day of surgery. And then the next morning, most patients drive themselves in the next morning with excellent vision. So that's the immediate post-op period. In the first couple weeks after the surgery, you're taking eye drops every day. And we usually see you back 2 to 3 weeks later. And at that point, most patients have excellent vision.
Dr. King, I would like maybe to bring you in and to talk about the LASIK or ICL or PRK, sort of that same journey, if you will, what that experience is like for patients, please.
For patients who really want to just get their vision corrected. We offer same-day consultations and procedures. LASIK is a fairly straightforward procedure where once we know what a patient's prescription is and what the cornea looks like, following an examination of the eye, we can actually do the procedure on the same day. And that's something we commonly do. We've got a lot of patients who come to see us from parts outside of our immediate geographic area, and they'll fly in and have the procedure done following the testing done in the morning. So for a LASIK patient who's local, who would like to just simply find out if I'm a candidate, you could come in and have all the testing done prior to scheduling a procedure. That's complimentary. And we can advise of what the procedures are. If someone were interested in an ICL, it is essential to have these measurements done in advance because we need to order the lenses. The lenses are shipped to us custom for each patient. So if there's interest in LASIK or PRK or an ICL, you can certainly come to the office, but if you would prefer to do a same-day LASIK consultation, we can schedule that at your request.
Well, I've got you. Could we talk through astigmatism? I guess it's astigmatism is one item, and then Dr. Kopstein, I'll have you talk about dry eye. But question I've got is, what is astigmatism, and is it treatable with LASIK and ICL and refractive lens exchange? Please.
Well, astigmatism just refers to irregularity in the cornea. I happen to have with me a little lens that I was using today to look at people, and it's a spherical lens. And this lens we use to look into the back of the eye. And as I rotate it around, there's no difference in power. But if anybody has astigmatism in their glasses or their contacts, you may notice that as you tilt the lens, there's going to be some blur developing. And what that means is that there's more power in one meridian than in another. And that can be corrected with a variety of techniques. With LASIK or PRK, we can incorporate that astigmatism correction into the laser treatment that's applied to the cornea. If a patient's having an ICL, often we can place a toric lens. And the same thing for refractive lens exchange. By placing a toric or astigmatic correcting lens, we can treat that astigmatism. There are a number of other techniques that can be used as well, such as placement of the incisions in the cornea or relaxing incisions in the cornea. But the bottom line is we want each patient to see as clearly as possible after their procedure. And for nearly everybody, it means getting rid of that astigmatism and treating it. So we plan for that for essentially every treatment that we do, whether it's LASIK, PRK, ICL, or RLE.
Dr. Kopstein, we've been getting a few questions about dry eye and whether or not refractive lens exchange helps it, or causes it, or anything like that. What's your thoughts on that, please?
Well, with refractive lens exchange or cataract surgery, the incision that we use to do the surgery is only 2 millimeters, roughly 2 millimeters. It's at the very edge of the cornea, so it does not disrupt the reflex from the eye to the brain that allows the brain to stimulate the little gland on the eye that makes tears. So if you disrupt that reflex, you could end up with dry eye. RLE or cataract surgery, the incision is so small that it does not disrupt that reflex. So dry eye after RLE or cataract surgery is not something that we have to worry about. It's more of an issue for some patients who have LASIK surgery because you're making a flap of the cornea that goes all the way through the cornea, and those patients have a risk, although it's a small risk, of developing chronic dry eye. Not the case with RLE or cataract surgery.
I've got a question here from Lori, which is, bear with me here. What's the difference between the multifocal lens and a light adjustable lens?
Yeah. Two different technologies. Let's see, what's the best way? So let me just give the example of the patient that I literally just saw. She's 53. She has totally healthy eyes, but she has to wear her glasses for pretty much everything. Okay. She is a candidate for a multifocal lens. The nice thing about multifocal lens, the best thing about multifocal lenses is that we really don't have anybody who needs to wear any glasses at all after refractive lens exchange with a multifocal lens. There might be a couple outliers or here or there, but we say virtually 100% of people will be glasses free when they use a multifocal lens. Unlike this patient who I just saw, there are many patients who should not get multifocal lenses. And that has to do with anatomy. It has to do with any previous surgery, anything that could be wrong with the retina or the cornea in the back of the eye, something that has nothing to do with their natural lens. So the most important thing is to rule out those patients who are not candidates for multifocal lenses. This is something that we do all the time, every day. If somebody is not a candidate for a multifocal lens, the next best option for getting completely out of glasses, this means when we ask you 3 months after surgery, do you always, sometimes, or never wear glasses? We're looking for the patients who say, I never wear glasses, okay? With a light adjustable lens, that number is about 90%. So we can get 100% of patients out of glasses with a multifocal lens, virtually 100%. And we can get about 90% of patients out of glasses completely with a light adjustable lens. So that's the number one difference. The second difference between the two lenses is that the multifocal lens, it always has a ring design. Do you have a sample of that or a model of that? Because
I'll get that in a sec.
okay. So the multifocal lens has a specific design. Every multifocal lens of every manufacturer since the mid 90s has come out with these lenses that have these little rings inside of the lens. With the newest multifocal lens implants, the rate of seeing those rings and being bothered by them is somewhere between 1% and 2%. So it's not a high risk of seeing the rings or being bothered by them. But we know that every time that we put in 100 of these multifocal lenses, we're going to be removing 1 or 2 of them. And that's just how it is. There's some patients whose brains will never adapt to multifocal optics. The reason that is that those rings are important in order to give the reading vision and a full range of vision from about 10 inches from your face to theoretically infinity. So you need to have those rings in order to achieve the spectacle freedom. But those rings have to split light when they come in through the lens. So we see some patients, about 1 or 2%, who will be bothered by contrast reduction to the point where they want to have the lens out. Or they'll see the rings around lights and it just drives them crazy. That's 1 or 2% of patients. If we remove that lens and replace it, we always replace it with a light adjustable lens, almost always. And the reason we do that is because with the light adjustable lens, you can't beat the quality of distance vision with any other implant. Because the lens itself does not have rings on it, it's very clear and it has a depth of focus to it that allows near vision. The third thing about the light adjustable lens is that it's adjustable. So if somebody doesn't have all the near vision that they want after the first treatment, then they'll come back and they'll say, okay, can I have a little bit more power for reading? And when we do a second adjustment, this is the only lens that can be adjusted when it's actually in the eye. All the other lenses you have to take out and put something else in. The light adjustable lens, we can adjust when it's in the eye based on what the patient says. So if the patient comes back and says, okay, I have my great distance vision, I can see my computer, I can read my cell phone, but sometimes I look at a little pill bottle and I can't read it. Okay. Well, then we'll try to add power to one eye to the point where they can read that little pill bottle or whatever they want to read up close. And then we'll let them go for a week or two and just make sure that it doesn't bother their brain to have a difference between the two eyes. And for about 90% of patients, that works beautifully. The other 10% of patients will come back and say, I don't like this difference between my two eyes. I feel like I see double, or I have to use one eye and then the other eye. And if that's the case, then we try to find the happy medium. So we can adjust it back to distance. We can bring the distance eye in to meet the near eye. There's a number of different techniques that we use to adjust the lenses after surgery so that people feel comfortable with their vision and they don't have to wear glasses most of the time. And that's about 10% of patients who have to find that happy medium rather than I have my perfect distance and I have all the near that I want. That's 90%. 10% have to find that happy medium so that they will limit the amount of time that they use glasses.
Dr. King, I know that we've got you for a little bit longer, and then Andy will we'll do the baton pass, and he'll handle the tail end of our time together. Anything that any questions that you've been answering? I know I saw a couple there about how long the person's prescription needs to be stable, but is there anything that maybe stands out while we just have a few more minutes with you about anything you'd like to say or any answer that to the question that maybe you've been answering there, please?
Well, there's a lot of questions. For example, here's one question that I think pertains to the risk. And I'm sure everyone does have some concern about the risks of the procedure. Each patient is going to be advised prior to the surgery about what the potential risks are. And historically, I'll start with LASIK. There has been some risk of glare and halos at night. Now, that has really been reduced significantly with the development of new laser technology, which allows for wider treatment areas, blending of the treatments, tracking of the laser treatment so we don't have decentration. And it's really an extremely uncommon complaint now. When I first started doing LASIK and we were using much smaller optical zones for LASIK, it was a more common concern, but we really don't see that anymore. Any surgery on the eye can be associated with the development of dry eye. And if the dryness of the eyes persists beyond the typical couple of weeks post-operative, there are remedies for that. It might be outside the scope of what we're going to talk about here, but just briefly, there are a variety of things like lubricants and masks and dietary supplements and medications that can be used, punctal plugs, etc. These are not common things to be needed because for most patients, nearly everyone, the dry eye resolves within a couple of weeks. But I like to just emphasize that LASIK is really one of the safest procedures that's ever been developed. Nobody has ever lost his or her vision from a LASIK procedure, to the best of my knowledge, or for a PRK procedure. With respect to an ICL, the biggest risk that somebody faces is probably a residual prescription. So if you're having a lens placed in the eye and there's a residual prescription, we can either adjust the position of the lens or exchange the lens or do a LASIK touch-up or a PRK touch-up to really fine-tune the results after a refractive lens exchange. Dr. Kopstein's talked about how we will adjust the outcome for patients with a light adjustable lens. So we're really not needing to do these LASIK touch-ups or PRK touch-ups after a light adjustable lens. But for some patients who have a small residual prescription following a refractive lens exchange, we might consider doing a LASIK touch-up or a PRK touch-up to treat that residual prescription. So it does sometimes, for some patients, require a little bit more time to kind of work through some of these post-operative issues, whether it's a little clouding behind the lens implant, which would require a posterior capsulotomy laser procedure. But typically within 3 or 6 months, certainly, nearly everybody's in good shape and where they would like to be. So Dr. Kopstein, did you want to make any other comments about procedure risks? I can say in your hands, though, and before I let you answer that question, I would like to just make one point about surgery. And it's a skill that requires practice. And the more surgery you do, the better you get at it. It's similar to probably playing an instrument or shooting a basketball from the free throw line over and over and over and over again. The more times you do this, you've got muscle memory and experience in dealing with complications, et cetera. And I can say Dr. Kopstein is truly an exceptionally gifted intraocular surgeon. And intraocular surgery carries with it some risk, obviously, of things like infection or potential complications. But in the hands of an experienced surgeon, the risk is extremely low. And if a rare complication ever arose, it would be appropriately handled. So I think if you're considering an RLE, it would really it benefits you to look for somebody who really just specializes in having or doing this procedure over and over again.
Dr. Kopstein, I've got, do you have any comments or can I ask you a question, Andy?
I was going to say two things. Thank you, Joe. Number one is, Malcolm Gladwell's thing of, you need 10,000 hours
10,000 hours, yeah.
of doing something. I was thinking about that the other day because I think after I'd done about 10,000 surgeries, I was, I think that's a pretty good metric, but not every surgery doesn't take an hour. So I was thinking, okay, well, what does the average cataract surgery take in the United States? I think most surveys will tell you about 20 minutes. So I think like if you can find a surgeon who's done over 30,000, now you're getting into that range of surgeons who can, quickly get in and out of the eye, who have probably done enough surgery where they've seen all different kinds of anatomy and nothing surprises them anymore. And that really does reduce your risk significantly. So I think like that over 30,000 threshold is probably fits with Malcolm Gladwell's book. I think that was Outliers, if I recall.
Yeah, it's a great book.
Um, so I think that number one. Number two is that anytime you go into the eye for anything, there's always a risk of infection. Okay, the published rate of infection for cataract surgery or refractive lens exchange in the United States is about 1 in 1,400. So that's 1 out of 1,400 is the rate of infection in most published reports. There was recently a very large study done in India of over 100,000 patients where they had 0 infections. Now, how could that be? Not everybody is an experienced surgeon who's done more than 30,000. So what they did that was unique is they injected antibiotics at the end of the surgery. And so we've just started doing that recently on the basis of that report. My infection rate personally is way too high. It's 5 out of 50,000 surgeries. Even 1 in 10,000 rate in my view is too high of a risk. We want 0 if that's at all possible. So we basically do everything that we can to prevent infection. When it happens, it's horrible. It's the worst thing that can happen from eye surgery. And I can't tell anybody that the risk is 0, but it's roughly 1 in 10,000.
I wanted to ask you a question, Andy, about so we've got some questions like from Penny here. She's 45, had LASIK back in 2002, is now kind of noticing the reading isn't as crisp unless she takes her contacts out. So you got people in that 45 to 50 range. Then you've got other people that are like wanting, kind of starting to feel that they're that maybe in their mid 50s and early 60s, where their lens is starting to become more dysfunctional and they're starting to think about cataracts. So I guess my question to you is, um, how does RLE factor into cataract surgery is the first part. But then I guess the other part of the question is, what are you finding is the sweet spot, the age-wise, or where the lens needs to be, where RLE is the right option? So cataracts and RLE, and then sweet spot of age. What are your thoughts?
Well, my thoughts are this is an individual issue because I would first ask the 45-year-old, why is she wearing contacts if she had LASIK? Right? Because the whole purpose of doing LASIK is to be out of contacts. So it either has to do with the fact that her cornea, where she had LASIK done, has changed, or more commonly, the lens inside her eye is changing. All right. If it's the cornea that changed, well, oftentimes Dr. King, who is incredibly skilled at this, can lift the old flap, do a little bit more LASIK, and put the flap back down, and she's good for another 10 years until her lens really does fail. Okay. If the problem is not her cornea, but it's actually her lens, well, then she's looking at something if she wants to get out of those contacts and she doesn't want to struggle reading, then she's really looking at having a refractive lens exchange with the light adjustable lens, which is the lens that we prefer in all patients who've had previous LASIK. Okay. So that's number one. Number two is once you get to be 57 years old or older,
Mm.
I have never seen a patient who has a functional lens. So at that point, you just start the clock. And most patients within 20 years of being 57 years old will have cataract surgery in the United States. The average age of cataract surgery is 75, where 80% of people by age 80 have had their cataract surgery. So the likelihood is that removing the lens after age 57 and replacing it with a clear implant is always going to improve quality of vision for virtually all of these patients.
Well said. Christian, actually, I wouldn't mind if you wouldn't mind jumping on. Wanted to kind of give you an opportunity to number one, answer any or ask the docs if there's any questions that, and thank you by the way for answering them. Are there any questions that maybe you'd want the docs to handle that would be good for the group? And then number two, if you could talk through pricing and financing, please.
Sure. I think before Dr. King leaves, one of the questions we've had actually a few people who've had retinal detachments, have not had their lens replaced, and we're wondering if that would be a problem. So I said I'd throw that to the group to talk about. So I'll let you guys discuss that.
If you've had a retinal detachment, the likelihood is that you had it repaired by a retina surgeon. Okay, so the question is, how did that surgeon repair the retinal detachment? If they just used a laser to seal the hole in the retina so that it wouldn't detach again or get worse, then that has no effect on the lens of the eye, and you're just like anybody else who once you get into your 60s or 70s, you'll start to get a cataract, and then you'll have cataract surgery, or you'll have refractive lens exchange before you have a cataract. If the retina surgeon saw a big enough tear that they had to go into the back of the eye to remove the vitreous and then laser around the damaged retina, virtually 100% of those patients will develop a cataract within the first 3 years after the surgery. In that case, the solution is cataract surgery.
Awesome.
Excellent.
And then the last one for Dr. King, if you could clarify ICL, when it's best time to use ICL, when it's best time to use LASIK.
For a person to be a candidate for an ICL, you would need to have a prescription within the range for which the ICL has been approved by the FDA. And typically that's -3 to -20. The prescriptions, if a person has nearsightedness less than -3, we cannot offer an ICL in most cases. If the prescription is close to -3, perhaps an ICL might be appropriate. So the prescription is one consideration, but we also need to ensure that there is room to place the ICL lens inside the eye. So that's known as, that measurement's known as the anterior chamber depth. And depending on what the person's anterior chamber depth is, we may or may not be able to insert the lens. It's rare to find a nearsighted person who does not have room for an ICL. However, for farsighted patients, and maybe somebody here is under 45 and they're significantly farsighted, an ICL can be done, except we would do it in Canada. In fact, I yesterday treated a patient from the Seattle area whose prescription was almost +10, which is a huge prescription. And she was a unicorn with room to put a hyperopic ICL here in Canada. They're not yet FDA approved. So it really depends on the patient's prescription and the size of the eye, whether an ICL can be treated. But anybody typically who's nearsighted with astigmatism, if you're eligible for LASIK, you're probably eligible for an ICL as long as your prescription is above -3.
Excellent. Christian, anything else before I have you pivot to talk through pricing and insurance and financing?
I'll jump to that.
Please.
A lot of questions about insurance, a lot of questions about pricing. So I'm just going to run down all the pricing first, then I'll talk about insurance. We'll start with LASIK and PRK. It's $29.99 per eye, so $3,000 an eye. ICL is $4,000 per eye. And refractive lens exchange, we have different lenses we've discussed on here. So they range between $6,400 to $8,400 per eye. The light adjustable is the the most expensive one. That's the $8,400 one. But the reason for that is because we're using light treatments. We're using a device to change the shape of the eye as well. So those are the all-in costs for everything. There's no added cost to anything else. Insurance really doesn't affect folks on the LASIK and ICL, although sometimes people do have VSP, which sometimes does jump in and provide some sort of payment. But you can use health savings cards. You can use your flexible spending for that. You can also do that for RLE. Sometimes Dr. Kopstein will see a patient who has a cataract, and we use a third party for your insurance where we will send out the claim if he diagnoses you to have a cataract to your insurance. Everybody has different insurance. We don't claim to be the experts of knowing what your insurance will pay, but with the proper documentation, this third party is able to send that claim on your behalf. And we just charge it's kind of a concierge fee to do it, to pay for this service. Some people choose to do it on their own. We're happy to give you all the codes to process it on your own. But that's typically how insurance works with these procedures.
And then anything on the financing side, and then also the offer that we have for people that would like to schedule the consult, if you don't mind, please.
Sure. People can pay a variety of different ways. I briefly mentioned, with their HSA, FSA. We also offer financing for folks. It doesn't change the price, but makes it a little more palatable. And we offer 24 months, 0% financing. Sorry, Michael, what was the other question?
Just about the special offer we have for those that like to schedule.
As people are asking some wonderful questions, we'd be happy to see you in any of our offices. We have offices in the Seattle area. We have Linwood, Tacoma, Tukwila. That's our surgical office. In the Portland area, we have Vancouver, Washington, and Tigard. Eastern Washington is Kennewick. And we have a Scottsdale, Arizona office. And we'd be happy to see everybody come in. We can take an in-depth look at your eyes. And for those folks who want to do that, we kind of value this as kind of a virtual consult that we would do for you. And we put a value on that of about $500. And so anybody who wants to schedule by next Tuesday for one of these appointments, and if you elect to have surgery, we'll take $500 off your surgery because you spent some time with us today. You can do that either by calling us. You can call our numbers. I don't know if you've got that up, Michael. Our phone
Yep, it's on the screen.
Yep, you can call any of those phone numbers. Our staff's happy to help get you scheduled, and work out a time that's convenient for you.
Wanted to, just because we're kind of rounding out our time here, to maybe tackle the question, and I know we've talked about this a little bit, gentlemen, which is what sets King LASIK / K2 Vision apart. But from a patient's perspective, like they have options for their vision care. What again, just to kind of revisit that topic, Dr. Kopstein, what do you think does set us apart as far as, at the very least, the right place for somebody to choose for having that conversation, that consultation? What, in your opinion, sets us apart, please?
I think there's really two things. Number one is our experience, not just as surgeons, but also as decision makers, not just in doing how many procedures have you done, but also knowing what those outcomes are. And having a robust database to refer to, so that we can clearly articulate what your outcome should be or will fall within this range. Once there's enough patients in the database, the likelihood of finding an outlier gets lower and lower. So we can show that, and it's very uncommon for somebody to be an outlier. So you get a really good sense of what your outcome should be. So that's number one, is experience. Number two, I would honestly say that our staff is really phenomenal. I mean, on the one hand, we tend to hire really nice, lovely people. Okay. But the second thing is that we're never in a hurry because we've intentionally kept our surgeon schedules light. So we have plenty of time to spend with patients before surgery, during the consultation, after the surgery. It's a nice touch to have all of the staff focused in on one thing. So this is really all that we do, and I think we've just hired the best people to give the patients a great experience.
Dr. King?
I'd like to thank everybody for joining us today. We hope it's been helpful to you, and we hope we've answered some of your questions. If you would like to learn more, we invite you to come either to the office or schedule a consultation at any of our locations. We have offices in Linwood, Washington, Tukwila, Washington, where we have a surgery center, Tacoma, Washington, Vancouver, Washington, Tigard, Oregon, Kennewick, Washington, and Scottsdale. Be a pleasure to see you. And should you decide to have a procedure done, great pleasure that you would trust us to help you to see more clearly. Thanks so much for joining us. I will log off now, and
Yeah.
I appreciate everyone's coming to the webinar today.
Yeah, and I'll to carry us over the finish line. Thank you, Dr. King. It really, from our perspective, it's again to end where we started. Today isn't about deciding to have surgery. Today is about having a conversation, and hopefully through the time that we've had here, you can see the approach that we take. Very organic, engaging, putting your needs first. And so we'd love to have that conversation with you, to invite you to come into our practice. And because you're going to probably leave, we will send every one of you the recording, but you're probably going to leave and have more questions, and that's a good thing. And so that conversation, which is free at our practice, will give you that opportunity to kind of find out, is this right for you? Is the timing right? Like, we want to kind of find out uniquely where you're at in your life and be of service to you. So, Christian, before we conclude, is there anything else that is a hot question that maybe you want Dr. Kopstein to answer? Please and thank you.
No other question for him. Just a question about this little offer we had.
Yeah.
You don't have to have your appointment by next Tuesday. You just need to schedule it by next Tuesday. So some people have said, "Well, I'm going to be traveling for Memorial Weekend." We don't anticipate you coming in today. So please give our office a call if you'd like to come in. We'd be happy to get you on the schedule. And just when you talk to a person, just let them know you're on the webinar, and they'll just designate that little special discount we gave you.
Dr. Kopstein, do you have a few questions about which offices each surgeon does the procedure? Maybe if you kind of want to talk about some of the other docs we have, I think it'd be appropriate, please.
Yeah. So I personally go to all 4 of the offices. I'm in Tukwila 3 Wednesdays and Thursdays out of every month, and in each of the other offices at least once for every month. We have Dr. Fillmore, who is in our Eastern Washington office and sometimes also comes down to the Vancouver office. Fantastic surgeon. Dr. Lauren Schlecht, who is probably the only surgeon in our group who's done more surgery than I have. Phenomenal surgeon, and just a great guy. He is typically actually he'll go to all 4 offices, but usually in Tukwila, Vancouver, and Scottsdale. We have Dr. Rex Hamilton, who has joined us down in our Scottsdale office. I call him the surgeon to the stars. He has a Beverly Hills practice and used to be the head of the UCLA refractive surgery program. He's a phenomenal addition to our group. Have I forgotten anybody?
No, I think you're good. That's great. Well, ladies and gentlemen, I want to take a moment and thank you for your time. Amazing questions. Andy, we had 116 questions, which is phenomenal. And it just kind of, I think, details the desire for people to get answers. And again, we're super grateful for you spending time with us here today. Hopefully, this is the start of the conversation to help you get that visual freedom that you're looking for. We'd love to see you in the practice. someone from our team will follow up with you and kind of just reach out and see if if you haven't scheduled, if you'd like to schedule. But again, on behalf of all of our doctors and staff, thank you so much for spending time with us here today. Dr. Kopstein, I will give you the last word. What do you got?
Okay, I'll say one last thing. Just call us. Okay, we have time for you. If you want to get in that week or the next week, like I said, we keep our schedule intentionally light. So you're not going to come into our office and see 30 people waiting in our waiting area. You're going to get all of your questions answered virtually within an hour of the time that you enter our office. You're going to leave with all of your questions answered. So just give us a call, set up an appointment. There's no hurry. There's no rush to do surgery. You have the rest of your life, and we just hopefully will give you the best vision during that time.
Awesome. Thank you so much, everybody. Have a wonderful rest of your day. Thank you for your attention.